Good afternoon. Welcome, everyone. We will be starting in just a few minutes. Thank you so much for completing the demographic questions while we're waiting to get started. Good afternoon, everyone. Welcome to the webinar. We are just waiting for a few minutes while people join the webinar. I can see every second someone is joining. Please go ahead and complete the demographic questions while we're waiting for people to join. Good morning, good afternoon. Welcome to the webinar today. We're just waiting for another 30 seconds or so while people join the webinar. Please go ahead and complete the demographic questions while we're waiting. Good afternoon, good morning, wherever you are. Welcome to today's webinar. My name is Ruan Barnabas. I'm the Chief of the Division of Infectious Diseases at Massachusetts General Hospital, and it is my great pleasure today to introduce our speaker, Dr. Grant Ellsworth, who's at Weill Cornell Medicine in New York City, in New York State. And he will be presenting the IAS-USA webinar today on screening and prevention of anal, cervical, and oral oropharyngeal cancers in people with HIV. Here you will see the disclosures for the content on the web board. The disclosures for the presenter, moderator, and peer reviewers are listed here. The IAS-USA designates this live activity for a maximum of 1.25 CME credits. The webinar is also approved for 1.25 hours of ABIM, mock points, and nursing, pharmacy, and pharmacotherapy credits. Generous support for this activity has been received from the following contributors. The on-demand recording and slides from this webinar will be available within 24 hours. A separate window will show the poll questions today. Please submit questions using the Q&A button. We apologize if we're not able to address all questions in the allotted time, and the chat is open. It is my great pleasure to introduce our speaker today, Dr. Grant Ellsworth, and he is going to talk to us about screening and prevention of anal, cervical, and oral and oropharyngeal cancers among people with HIV.
Thank you, Roanne. It's a pleasure to be here. I really appreciate this opportunity to talk about this important subject. As mentioned, I don't have any disclosures. I do want to mention that most of the research in my talk is presented in gender binary terms, which generally refers to sex at birth. So today, what we really want to cover is talk about the epidemiology of these three cancers related to HPV, primarily in persons with HIV. We're going to talk about the new guidelines regarding screening for and preventing HPV-related cancers in persons living with HIV, and how emerging data and research is going to likely lead to additional changes. And then finally, we're going to end off talking quite a bit about the evidence behind HPV vaccination, and why we should really be focusing on the youth for this intervention. So this is our first question, just a poll to kind of give us a sense of what's available in your clinical practices. So just give you guys a few minutes to respond to this. All right, probably about 10 seconds more. So basically we want to know if in your clinical practice, what type of access do you have for anal cancer screening or high resolution endoscopy? If whether you can refer within the clinic, you do this yourself, or you're not sure or even understand what this means. That's a valid response and a good reason to be listening. All right. So it does look like this is much better than last time I get asked this question, but about 37% don't quite have access, it looks like. So we'll talk about this as we go along. All right, so we have two questions today. The first question regarding kind of how HPV-related cancers affect men versus women. So which HPV related cancer occurs more frequently in men than women in the general population? And I should put the caveat here in the United States specifically, because outside the US, it's harder to get kind of accurate data on some of this. So answer A, cervical cancer. Answer B is anal cancer. Answer C is oral cavity, oropharyngeal, head and neck cancer related HPV, or answer D, genital warts. All right, I think we can probably move on. And so we'll talk about the answers as we get through this. And next question. So at which age do the updated National Institutes of Health, CDC, opportunistic infection guidelines that were released in July recommend initiating anal cancer screening in women with HIV? Answer A, 21 years, B, 35, C, 45, or D, at the time of HIV diagnosis regardless of age. All right. Excellent. Lots of responses. This is good. I appreciate the questions that were submitted, and I hope to cover many of those as well. So this is just an HPV primer, particularly for people that really haven't, maybe practicing outside the field of HPV-related cancer screening and prevention. I really haven't thought about this since medical school. But when we talk about cervical or anal cytology, we're typically talking about liquid-based cytology, not the traditional pap smear where we do direct smears onto a slide. And when we talk about abnormal cytology, we're thinking of anything that's more severe than ascus or atypical squamous cells of uncertain significance. All of these categories are considered abnormal, and really the only normal result is the no evidence of epithelial lesion or malignancy. Okay. And then in terms of lesions, they get categorized as benign, low grade interepithelial lesion. So examples of low grade are warts, or there can be flat low grade lesions. These are not considered to be precancerous, and kind of the prior terminology would put these all in these categories of category 1. And then high grade lesions are considered precancer. And in fact, are really carcinoma in situ. That's carcinoma, basically cancerous cells above the basal membrane, and are categorized as these. And then finally, the lesion that we're really working to prevent is invasion of these high-grade lesions, which is then defined as cancer. So HPV typically only infects squamous cells. And so typically enters through cuts or breaks because it has to infect the basal layer cell. And then, as time goes on, this can develop into various grades of lesions. And ultimately, if the infection persists and causes multiple cellular changes, um, it can result in invasion. Now, there's various ways that this pathway could be cut off. One is, antibodies through, say, vaccination can prevent the initial infection. Cellular immunity, such as natural killer cells, can kind of clear these infected basal cells. And then various things can really push the whole process one way or another. Low CD4 counts or a history of a low CD4 nadir. Antiretroviral therapy can shift things to the left. We'll talk about that. And smoking, as in any cancer, really can increase risk. Um, so really, what we do know about HPV infection is the vast majority of HPV infections end up getting cleared, and really don't develop into any sort of lesion. The infections that do persist can over time develop into high-grade lesions, for example, and then these lesions over time can either go away on their own or persist. And then, you do worry about the very small number of lesions that become cancer. But so just to reinforce that most HPV infections don't obviously ever make it to cancer, and most HPV infections don't even make it to high-grade lesions. So the lifetime risk in the general population to acquire HPV is very high. And this is based on data in the United States. Just through heterosexual contact, the risk is about 84%. And about 80% of men and women will have acquired HPV by the age of 45. Now, certain populations probably have higher rates of exposure. So men who have sex with men, this is likely higher. And we have some studies that show if you just take a group of men who have sex with men and screen them for anal HPV infection, up to 90% of that group will have a detectable infection at any given point in time. In terms of HPV-related cancer cases in the US, it's about 38,000 based on data from about 2016. And what we're seeing is this rate is increasing at a rate of about 2% per year, like many other cancers. Now, cervical cancer is the real concern when we look at HPV-related cancer globally, because it does cause an enormous amount of death in women. And in low and middle income countries, it is the leading cause of cancer death, particularly in areas like sub-Saharan Africa. Whereas in higher income countries, this shifts into more to breast cancer being the number one cause of cancer death. And many of these cases occur in low resource settings where limited treatment options are available. So where are we going in the US? Well, great news, cervical cancer rates are declining in the general population. And we've seen an accelerated pace of decline in the post-vaccination era. I'll show you some of that data later. However, anal cancer cases are increasing now. If we look at the general population, this is actually still a very rare cancer, but is increasing faster in men. It's increasing in both men and women at a rate of around 2%. Now, the real thing we really need to talk about, but really don't have a lot of options, things to offer in terms of prevention, is oral and oropharyngeal cancers. These are rising rather quickly, particularly among elderly men, at about rates of 3% a year. A good the vast majority of these are attributed to HPV infection. And people are not doing well when they're being diagnosed with these cancers. And we reached an inflection point in 2010 in the United States where the cases of oral pharyngeal cancer in men started to exceed the number of cases of incident cervical cancer in women. So that should go back to make you think about that pre-test question that we asked you. And so this is the HPV-related cancer that occurs more frequently in men than women. So men are more likely to get oropharyngeal cancer than women, about 5 times more likely. And then since, we really want to talk about persons with HIV and their HPV malignancy risk, and across the board, HIV increases the risk of developing cancer compared to the general population. For cervical cancer, women with HIV are 6 times more likely to get cervical cancer. Anal cancer in all comers is about almost 20 times higher, and up to 40 times higher in men who have sex with men that are with HIV. And oropharyngeal cancer, we have a little bit less data, but it looks like they're about 2 to 3 times more likely. Persons with HIV are 2 to 3 times more likely to develop oral and oropharyngeal cancer. And now the cancer risk related to HPV-related cancers is associated with has been associated in various studies with the number of lifetime sex partners, a prior history of AIDS, a history of low CD4 nators, and smoking status, among other factors. So this is a kind of a confusing graph, but it's a very important thing. This is really the best data we have on anal cancer incidence and risk based on demographics and HIV status. It was put together by Gary Clifford from the International Agency on Cancer Research of the WHO. And it really highlights the groups that are most at risk for anal cancer, being men who have sex with men, particularly with HIV. And this risk increases with age. As you can see in this upper corner here, men who have sex with men with HIV over the age of 60 have incredible rates of cancer. And these rates actually approximate the rates of other common cancers. Men with HIV who don't have sex with men do still have an increased risk of cancer. Women with HIV have an increased risk, and of course, this increases with age. And we shouldn't, even though this is a lecture about HIV related risk, there is increased risk of anal cancer in persons without HIV, including women with vulvar precancer and cancer, and solid organ transplant recipients, and that risk increases over time since after transplant. So just to put this in perspective, this gray line here is the approximate historic rates of cervical cancer prior to widespread screening. This is the approximate rate of current cervical cancer rates. And then this is kind of an arbitrary 10 times the rate in the current rate in the population, which is 10 times that rate's about 17 per 100,000 person years. And this will become important, kind of is the cutoff that determines some of the screening groups in the new guidelines. One group I'm frequently asked about is men who have sex with men who don't have HIV. It was always hard to really tease this out because cancer registries don't track sexual orientation well, or sexual practices. But a colleague of mine, Ashish Desmonk at University of South Carolina, was finally able to kind of piece this together and show this increased risk of anal cancer in this population that increases with age, and really not that different to, say, heterosexual men with HIV or women with HIV. Again, there's that 10x of the rate in the general population. You can see these groups are above that. So just to put this in perspective, this is not super accurate data, but these are the rates of certain cancers in the general population, and compared with anal cancer, you can see that particularly men who have sex with men with HIV, the rates do approximate, very common cancers such as breast or prostate. Just to throw women in there as well, to show you the comparison. So this is a slide that was put together by another colleague of mine at Vanderbilt, Stacy Sundega, which I thought to be very useful, and she's given me permission to share it. But it shows this continuum from normal squamous cell mucosa to infection, progression to H cell to cancer, And again, a lot of this can go this way, and the vast majority of infections do get cleared. But just showing what the effect of HIV has on this process. So you take women with HIV and compare them to women without HIV, you see that women with HIV have higher rates of HPV infection acquisition. They are less likely to clear HPV. They're more likely to have high-grade lesions, and those high-grade lesions are less likely to spontaneously regress to normal. And so you can see that HIV alone can just push this whole continuum to the right and really cause the development of cancer. What is also interesting, and what we're going to talk about briefly, is the effect of antiretroviral therapy on various HPV-related cancers. So women with HIV that are taking antiretroviral compared to those that aren't, women on antiretrovirals have less prevalence of HPV, cervical vaginal HPV. They have lower incidence of high-grade lesions. Their high-grade lesions are more likely to regress compared to women who aren't taking ART. And they have a reduced risk of cancer. So just being on ART alone reduces the risk of cervical cancer by almost 60% versus women who are not with HIV who are not taking ART. And this has really been borne out in various studies. The infamous START study, which really revolutionized HIV care and justified the immediate start of antiretrovirals upon diagnosis. Um, Looking back in the study at incidence cancers in the two groups, you can see the rates of cancer increasing in the deferred arm, whereas they were actually fairly flat. And these are virally mediated cancers due to EBV, like leukemias and lymphomas, Kaposi's sarcomas, and HPV-related cancers. And so in the immediate ART, they saw 67% less cancer. Just another benefit to justify, of course, what we all accept as fact now, that people with HIV should be taking antiretrovirals. This is a meta-analysis of cervical cancer and ART that was done by a group and published in Lancet, just showing that 60% reduction, or about a 40.43% hazard ratio of the effect of ART on reducing cervical cancer risk. So I just want to talk, shift now to, I think the group's probably a little more familiar with cervical cancer screening and how that's done, and colposcopy biopsies and various ways to treat high-grade lesions such as thermal ablation versus LEAP. So I'm going to talk a little bit more about HRA because, as you know, one of the polls we saw, the initial polls showed that there are people that don't have access to this. So the way we perform this is we typically use a disposable plastic speculum, the operators, for comfort during insertion. And then we use acetic acid to enhance lesions. So here is a lesion. I'm sorry, it may not project very well, but you can see it's a little bit more white than some of the more normal mucosa. There's some vessels there. We use some iodine. This is the same lesion. It's yellow here. We biopsied this lesion. It did, in fact, come back as high grade. This is that same patient returning. This isn't highlighted as well here, but after the application of more acetic acid and Lugol's iodine, we were able to highlight this lesion. And the way that most people are treating these lesions, and we'll talk about this, is using this device or a similar device, electrocautery device, to essentially ablate the area. This is a partial treatment. This was going to get another pass, but just to show that we're essentially removing those infected squamous cells or affected squamous cells from the anal canal. Now, one question I got was, well, how do I, get trained in doing this? And the only way course that I'm aware of that's probably worth your time is put forth by the International Anal Neoplasia Society. This is easy to Google. It has been virtualized, so it can be done on your own time, but there are also kind of some live sessions as well as some guided Q&A. And that's a great start for people that are wanting to get to know a little bit more about this. In terms of it's pretty similar to the ASCCP colposcopy course, which is also available for those interested in learning colposcopy. Just to give you an idea, this is what an invasive cancer lesion might look like on our HRA. You see all these kind of gnarly vessels. It's definitely wide, it's raised. You probably could feel this on digital anal rectal exam. In the perianus, things can look a little different. So obviously this person with some increased melanin, obviously, but this is just pigmented lesions that are palpable or often concerning for high-grade lesions in the perianus. Now, why are we talking, we talking about this because about 3 years ago, this month, the Anchor study announced that it had stopped enrolling because it reached its kind of primary efficacy endpoint. And so they, just as an introduction, the Anchor study was a randomized trial in persons with HIV and high-grade lesions. And people entering the trial were randomized to monitoring of those lesions or aggressive treatment of all the lesions in their anus about every 6 months. And what we saw in the study is there was more cases of incident anal cancer in the active monitoring arm. But note there were still some cases in the treatment arm. And what really surprised investigators, including myself, was how much cancer was occurring in both arms, which is more than was actually anticipated at the time of design of study. And most participants were followed for about a period of 2 years. And then some people question why we even did this study. Well, no one actually knew that this strategy of treating or ablating these lesions would actually work. And a randomized controlled trial of cervical HSIL or high-grade lesion treatment was actually never performed. We just saw the epidemiologic benefits of doing cervical cancer screening. And this is a little bit more morbid in terms of treatment than cervical HSIL treatment. So nobody really actually knew if this was safe either. But this trial was able to demonstrate that yes, it was safe, and that we almost achieved a 60% reduction in anal cancer alone, attributed just to treating those lesions, screening and treating for those lesions. Here's that data in a Kaplan-Meier curve. You can see the clear these two curves between the active monitoring group and the treatment group really diverging here. The study also benefited from a great graphic designer. We have lots of cute graphics that I think really kept the participants engaged. There's still some controversies surrounding anal cancer screening, though. So like there were still incident cancers in the treatment arm. And it really points that maybe, ablation isn't the best treatment, but it's probably it's the best thing we have at this moment. And, had we had better clinicians working on the study, I'm speaking for myself here, maybe we could have prevented additional cases of cancer in the treatment arm. And so maybe we could improve those outcomes. But really what we probably need is also some adjunctive or novel therapies, such as HPV immunotherapeutics that can enhance H-cell clearance in those affected by this disease. The bigger controversy is there's not widespread access to quality high-resolution endoscopy. And there really is a need to scale up training programs. We probably need better screening tools because cytology alone, what we'll see is a lot of people will have abnormal cytology but won't have high-grade lesions, leading to kind of excessive HRA that may not be necessary. Perhaps there's other biomarkers such as HPV testing or even other things that we haven't evaluated that better identify at-risk persons. And there's probably a lot of HSIL that would regress without treatment. They never progress to cancer. We just really don't know which is which. So the current approach is just to treat everything that you find. And can we extrapolate these results to other high-risk groups, such as people without HIV or women with vulvar disease, for example? We don't know, but we think that probably yes. So the first guideline that was released in January of this year came from the International Anal Neoplasia Society, the same group that puts on the HRA course, and really looked at people with elevated risk and created this guideline. So starting at age 35 for men who have sex with men with HIV, transgender women with HIV at age 35, heterosexual men at age 45, and women at age 45. So this isn't the CDC NIH guideline, but I will tell you that matches. So that's the one question. And then these other risk groups without HIV that we talked about, men who have sex with men without HIV at age 45. And then doing a screening, which includes digital anal rectal exam. I can't emphasize this enough. This is not your quick prostate exam that we're traditionally all taught to do. And then screening with anal cytology plus or minus anal HPV testing. And those with abnormal results, which we're not going to get too much detail, and referring them on for high resolution endoscopy, and negative results repeating a screen in 1 to 2 years. Typically, most groups would be probably about 1 year unless you get a series of normal tests. So this is the Ian's guideline. I'm not going to spend a lot of time onto it because if you screen with cytology alone, it's different than if you screen with HPV testing alone versus if you screen with co-testing. What I will say is if you do cytology plus co-testing, at least in my practice, what I find is you can get a lot of abnormal cytology that you feel comfortable ignoring because there is no detectable high-risk HPV, and that person's probably at low risk for developing anal cancer. So this is a great strategy, hopefully going forward at least, and can potentially be approved upon. But this is what I think I'm really excited about is the NIH CDC group guidelines. Just as a disclaimer, I'm now part of the subcommittee for the HPV section, but I was not part of the development of these groups. And so basically it simplifies this. This is only for people with HIV, men who have sex with men, and transgender women at starting age 35, and all others at age 45. And then the first breakpoint is HRA available. And if the answer is no, it doesn't mean you don't screen for anal cancer. It just means that you do a limited screen based on symptoms and digital anal rectal exam. We have some unpublished data, at least for those entering the anchor study, that the vast majority of those who had prevalent cancers prior that were detected upon screening for the study had abnormal digital anal rectal exams. And so this is probably a fairly sensitive, but maybe not very specific way of detecting those. And referring them for standard endoscopy to look for obvious lesions. And this could be like an untrained colorectal surgeon. Somebody in the clinic could start doing this. But obviously, the preference would be if you had HRA, is collecting some specimens, but cytology, HPV testing, performing a digital anal rectal exam. You don't get out of that even if you can do HRA. And then deciding if you're going to do HRA based on the DARE or symptoms, or using your anal specimens. So the next figure here basically decides if you used HPV testing or not. If you used HPV testing, you go down this algorithm. If you didn't, you go down this algorithm. Now, I will note one thing I get lots questions, can I ignore ASCUS? And the answer is no, because a fair number of these people, you will find them to have high grade, even though it's not a HPV specific diagnosis on the cytology. We do recommend performing HRA. So just one last slide, because I really want to emphasize the digital anal rectal exam. The reason it's probably is important is we know that anal cancer outcomes when treated are related to essentially how severe the disease is, or the metastatic state. And localized cancers have great outcomes And it particularly localized cancers less than 1 centimeter often can be treated surgically alone. And the EANS does have guidelines on how to perform this, how to get better at it, how to understand if you're just feeling other anal diseases like fissures or hemorrhoids. And Richard Hillman out of Australia has also put together a great video essentially on how to improve your skills in this exam. There has been a shift in cervical cancer screening approaches in an effort to increase cervical cancer screening rates. In 2001, the WHO issued that there are new guidelines which dropped cytology altogether. This has been not without controversy. I'm just presenting it here, and essentially, in women without HIV, starting at an older age of 30, and screening with HPV DNA, and then in women with HIV starting at a lower age of 25 and screening more frequently. I think in the United States, we haven't caught up with those guidelines, and I'm not sure that we will, but in women with HIV, from the NIH CDC guidelines, there are these were not updated in the most recent iteration, but they did put these new figures in to help us understand more easily what we should do with the our cervical cytology results. Now, in women aged between under the age of 30, we really don't use HPV testing because at this age, there's a lot of transient HPV infection that's probably not clinically significant. And if you're using an HPV test, you're going to detect a lot of that and probably overscreen women. So the recommendation still is for you to use cytology alone, and then based on your cytologic outcomes, determines how frequently you follow up or if someone should be referred for colposcopy. Above the age of 30, there is a recommendation that you can add HPV co-testing. Again, the biggest reason for adding this is if you end up with an ASCUS cytology, potentially women with a negative HPV test, you could ignore it and rescreen them in the future rather than proceeding directly to colposcopy. So groups have been looking at HPV tests for a long time. And so traditionally, tests would screen for 13 to 15 high-risk HPV types and give you a plus or minus results. And newer tests are starting to group HPV genotypes into very high risk, HPV 16, moderately high risk, which is another group of HPV genotypes, and then lower risk genotypes. And what groups have been doing has been kind of determining different cutoffs for a positive HPV test. And for example, this is using a test made by Cepheid called Expert. Most people know this from the TV world, and some other assays. And looking what happens to test performance if you started dropping some of those low risk channels in terms of the ability to detect HSIL. And what you'll find is you don't lose a lot of sensitivity, but what you dramatically can improve specificity. Essentially, hopefully better identifying high risk women without doing excessive amounts of colposcopy. And there's a lot of studies looking at this going forward. We've done a little bit of this work in the anus. This was a study sponsored by the AIDS Malignancy Consortium, looking at women who have a little lower prevalence. We already talked about men who have sex with men that have that high prevalence of HPV in the anal canal. So it's not clear if using an HPV test alone will really be that discriminatory in some populations. But comparing to cytology, HPV had better specificity. And again, if you use a test like Expert, and there's a few others that are coming on market, you could potentially improve the specificity by ignoring some of those lower risk channels, and really you don't increase the false emission rate, or you don't increase dramatically the number of women with HSIL you miss by employing these changes. The real problem is we need these tests probably to have great negative predictive value. That meaning if there's no detectable HPV, you're unlikely to have a lesion. More research is needed. It's happening now. I promise it's going to come soon. The real issue is reimbursement's inconsistent. For example, a lot of payers exclude men from HPV testing reimbursement, and no HPV test is FDA approved for use in the anus. So really, this is going to move forward very quickly. I think in the next year or two, particularly, we have a large biobank from the Anchor study that's going to be very useful. This is where this is a strategy to increase the rates of access to cervical cancer screening. And really, I think this is going to be revolutionary in the field of cervical cancer screening, and that's allowing women to screen themselves by performing vaginal self swabs. Um, and so really what we've looked at in women with HIV, these tests will agree if you get a provider collected cervical swab at the same time a woman collects a self swab, there's really good agreement. And there's the little better specificity in the cervical samples than the vaginal samples, and that's probably because we actually, when we look at the vaginal samples, we're detecting more HPV than we are in the cervical samples. But a lot of countries and programs are already moving forward with this. I understand that if there is a HPV test that's going to have FDA, either has FDA approval or it will have FDA approval. And at a recent conference, colleagues from the UK were describing how this was moving forward. And for example, taking a van or a truck, parking it in a grocery store parking lot, allowing women to self-screen in the van, and then essentially following up with them in some electronic means saying that, yes, your test was positive, you should come in for further screening. And one of the pilots even described having a CT scanner for lung cancer screening in the other side of the truck. It's kind of amazing. In terms of the anus, we have less data. There is some data validating anal cytology cell sampling. I don't know, Mary, I'm not aware of any clinic personally that's doing cytology cell sampling in the anus. Alan Nitri from Milwaukee was able to show that anal HPV self-sampling was able to increase the clinic attendance to an anal cancer screening clinic. So this is an exciting area as well. Potentially when people are in clinic, maybe doing their STI screening swabs, they could also just do an anal self swab. And there's also research looking into using first void urine in women, just in women, as a way of screening for potential cervical HSIL. All right, I have a single slide. We're back to the elephant in the room on oropharyngeal cancer screening. We had a lot of pre-lecture questions on this. We're way behind in terms of what to do about this. It's not clear if there's really an identifiable precursor lesion like a high-grade lesion. They probably do exist. We're not sure we know how to find them yet. But what we do have, and what seems to be very promising, is a number of potential screening candidates, and a lot of these are actually blood-based. So using HPV-16E7 antibodies, for example, these will when people are diagnosed with oropharyngeal cancer, what a lot of research has done is gone back and looked at banked samples and looked at when these antibodies developed. And some people were almost nearly all persons diagnosed with HPV-related oropharyngeal cancer due to HPV-16 will have one of these antibodies in their serum. And this antibody will become detectable years before diagnosis, even decades. There's also been a lot of research about circulating HPV DNA, or some people call this a liquid biopsy. This is already becoming standard of care in persons being treated for cancer in terms of treatment response. And then there's even groups looking at deep sequencing that's showing that they could potentially even detect some people with high-grade lesions. So these are all potential screening candidates. And if you have one of these positive tests, the thought is as well, maybe you should start getting some type of serial evaluation with imaging or flexal nasopharyngoscopy or something like that. But this is all just very research based at this point, and nothing's really ready for real time quite yet. But given the rates of cancer we're seeing, this is going to be an exciting area in the future. Okay, we're going to spend the rest of our time talking about HPV vaccination and the data behind HPV vaccination. So one interesting thing that occurred in the United States number of years ago was the expansion of the FDA indication and the age range. From prior to this, it was up to age 26, and then they included essentially everyone up to age 45. So just to to clarify, and we'll do this again, an FDA indication isn't necessarily a recommendation. It's just that the drug maker or the investigators were able to demonstrate that there was some efficacy, at least in some subgroup, and it met the FDA criteria for efficacy. Okay. And the study that really was the basis for this was an industry-supported study in women in Colombia from the ages of 25 to 48 that really had no significant history of HPV, at least in the prior 5 years to entering the study. And what they looked at was this combined endpoint of preventing warts or cervical intraepithelial neoplasia or dysplasia or persistent infection due to one of the vaccine types in the quadrivalent vaccine. And what they found is women that were both negative for evidence of prior infection with antibodies and didn't have any DNA, HPV types detectable by DNA at study entrance, the vaccine was almost 90% effective at preventing this endpoint. Now, if they looked at women with evidence of prior infection from one of these types, the efficacy actually drops to about 65%. And then the approval got extended to the 9-valent vaccine based on an efficacy study in younger women, safety in other groups, and then just demonstrating immunogenicity in other populations, including multiple studies that have shown pretty good immunogenicity in persons with HIV. So again, FDA indications, not necessarily recommendations. So these are the current American Committee on Immunization Practices recommendations for HPV vaccination. And where you can start is at age 9. Early vaccination's fine. And through age 15, you can give 2 doses. And this is at least in the American recommendations. The primary age to target is 11 to 12. By age 13, you're already late catching up. And up through 26, vaccinations recommended in all groups. I will note it's not here. Persons with HIV are only eligible at this point, or it's only recommended to use a 3-dose series. Two and single-dose series are being evaluated. But what I want to highlight is here in this older group of persons over the age of 27, the vaccine is actually not routinely recommended, and it's based on the shared decision-making model. And hopefully I can give you some guidance on that today. And in fact, what they recommend is you actually don't even routinely need to discuss HPV vaccination in most adults above the age of 26. And just looking at the cost efficacy, if we did mass vaccination in the United States, it would be an extremely expensive intervention in terms of outcomes gained from that. So you might say, well, Dr. Ellsworth, aren't persons with HIV different because they're at higher risk? And the answer is, well, we'll see. We'll get to that. So just to look at some of the primary data behind a HPV vaccine. So I'm primarily an anal cancer prevention researcher. So we're going to start with that data. This is the industry-supported study looking at quadrivalent vaccine in men, without the majority of which entered this study without HIV. And what you'll see, these are the 2 kind of Kaplan-Meier efficacy curves. And the differences here are, these are essentially people that were HPV naive to the 4 vaccine types when they entered the study. And you can see those that were randomized to the quadrivalent vaccine had very little cases of anal dysplasia. And then this is the intention to treat population. So everyone that came into the study, regardless of their prior HPV history or evidence of HPV infection, you can see that efficacy actually decreases a little bit. And this is really the story that we're going to start seeing is if someone's not HPV naive, that the vaccine efficacy is going to decrease. So they took that same group that enrolled in the study and they followed them for an additional 10 years. And everybody that was initially randomized to placebo group received a catch-up 3 doses of catch-up vaccination upon study completion. And then they followed a good chunk of study participants over a 10-year period. And what they found is in that the group that got and it was initially vaccinated, randomized to vaccine, that there were no cases of vaccine type related warts, dysplasia, or cancer seen in that group over the 10-year period. So pretty much this is pretty high quality data suggesting that the vaccine protective effects of the vaccine are very long lasting. And I will mention that the catch-up vaccine group or the initial placebo group, there were actually pretty few cases of related disease in that group. This is a kind of an interesting study. I find this study really difficult to understand, but I'm sharing it with you for the same reason, because this is targeted younger men with HIV. And there's two things from the study that I think are take home. So again, everybody in this study got vaccine. There was no placebo arm. And what they did show is there was a lot less cases of dysplasia of dysplasia related to the vaccine types in those that were naive versus those that were previously exposed. But the really shocking thing from this study was by the time these men, by a median of 23 years, were screened, over a third of them already had anal high-grade lesions, and almost half of them had evidence of a prior exposure to HPV-16. So really, it's showing how early HPV acquisition occurs. So getting back to this older group, particularly this group of HIV, they're higher risk for cancer. Should they be that shared decision-making group that gets vaccination at an older age? Well, we've already tried to answer that question with at least one randomized clinical trial. This was from the ACTG, where they took adults over the age of 27 and older and randomized them to the quadrant fail and vaccine or placebo, and looked at these various outcomes, which were persistent infection due to the HPV types in the vaccine versus persistent anal high-grade lesions. And then I'm just going to note this one in a little bit, but this study was actually shut down early for fertility because they really didn't see any benefit in those receiving vaccine versus placebo. So there was no difference in outcomes. However, the researchers astutely did note that there was maybe a non-significant trend for less oral persistent HPV infection in the vaccine group than the placebo. And we'll come back to this fact in just a minute. Just note that that's a pretty wide confidence interval there. Okay. And then groups have looked at using HPV. This is based off, a lot of these studies got started off based off observational data of using the HPV vaccine at the time of treatment of high-grade lesions. And so this is one study called MAUVE. It was a randomized clinical trial of 180 women with HIV in Johannesburg that had cervical HSIL that were being treated with LEAP. And what they would do is they'd receive a vaccine starting just before LEAP, and then they would complete a 3-dose series. And versus the other half of women that were just received a saline placebo. And what they were really hoping for was the vaccinated group would have less high-grade recurrence or persistent at 1 year, and they didn't really see that in this study. And when we went back and looked at the HPV types causing the HSIL, what we noticed, there wasn't really much of a difference, but there was a lot of non-quadrivalent types causing HSIL in this study. So, thought maybe a broader vaccine such as the 9-valent vaccine that's currently approved in the United States and available here might be helpful. So that's currently being evaluated in this study called AMC-099 Covenant. It's fully enrolled, it's underway in Africa, and hopefully we'll get an answer from that soon. But I think a lot of us are not too optimistic. A a group in Amsterdam looked at 126 men who have sex with men with anal HSIL who were being treated with lesions that were randomized to quadrivalent vaccine or placebo. And they even followed them longer than a year, because one of the criticisms of this study is they just didn't follow people long enough. And they didn't really see any differences between the vaccine or placebo group at 18 months. So now real world data, we get to this. And so this is a bunch of about 4,300 cases of cervical dysplasia with matched controls coming out of Kaiser Permanente in Northern California. So very large observational study here. And what the researchers found is there is a benefit to at least one dose of vaccine. Benefit is greater in younger women who receive that first dose at a younger age. But by the time the women are age 21, there really wasn't a difference between the vaccinated and unvaccinated cohorts in this study. And again, even if you looked at 3 doses, maybe slightly more effective, but by the time, if you're initiating vaccine at age 21 or older, there really is no difference in outcomes. And this gets highlighted in a couple of large national cancer registries. So this is coming out of Denmark, and it's looking at age of vaccine and cancer cases. So, so this is in this study that basically women that were vaccinated starting before age 16, essentially there's very little cervical cancer incidence versus unvaccinated matched women at the same age. And then if you look at women that start a little bit older, you see this line creeping up over time. And then if women that are initiating vaccine between ages 20 and 30, there's really no difference between unvaccinated women, vaccinated women. And again, these are from national registries in countries that have high uptake rates of this vaccination. So coming out of the UK, similar study, it's a little bit more complicated to understand, but essentially looking at vaccine age and age of when vaccine was initiated. For cancer, you can see this red line, which is ages 12 to 13, 14 to 16, and 16 to 18, really creeping up towards that unvaccinated line if you start vaccinating at older ages. Now, this is really interesting because the red line is basically flat. And what these researchers have concluded when they go in and look at the registry, essentially women that have been vaccinated in this program have essentially cervical cancer has been eliminated in women born since, they were vaccinated at an early age, essentially. So very hopeful. Vaccine is having a major effect on cancers, but it's very clear that it has to be given early. And not to leave the anus out of this, this is from that same Danish Cancer Registry, looking at age of vaccination and anal cancer outcomes. Essentially, if you younger vaccination age versus an older vaccination age, there really is, you can see that things start to kind of align. And one thing that we've observed in the United States is that even since starting the vaccination program, we've seen epidemiologic drops in the groups that were eligible for vaccine. We're not sure if they received vaccine or not. We've seen a drop in the vaccine age groups just since the initiation of vaccine for anal cancer incidence. So really, honestly, this is very promising. Potentially could vaccinate me out of a job, and I'd be thrilled for that. So this slide, okay, now I see. I got some feedback that it was a little blurry, but on my laptop it's fine, but on this computer it's really blurry. But what this shows is the age at which women are acquiring HPV infections. And as you can see, this is a fairly vertical curve early in life. And by the age, early 20s, more than half of women have acquired high-risk HPV infections. And we talked about that 80% by age 40 is about here. So really, we talked about naive people are the ones that are going to respond best to vaccination, and you've got to start somewhere over here really to capture that group. Now, despite me saying that, we're not doing so poorly. I've read something in the New York Times the other week trying to convince me that we were doing really badly, but this is the number of women that have received at least one dose of HPV vaccine, based on some immunization surveys that CDC does. And the rates are actually they're okay. They're not terrible. So, we have rates somewhere probably around 70, 60%, 69, 70%. There's a little bit of a drop post-pandemic, as has been well documented. And despite these rates, what we've noticed is a significant drop in vaccine-related HPV infections in these groups. And interestingly enough, we're seeing some of that drop in the unvaccinated population, so maybe a little bit of a herd effect. But really, since initiating vaccine, we've seen a pretty significant 88% drop in these younger teens and an 81% drop in young women ages 20 to 24. So we're seeing vaccine effects in a very large population. Okay, we're going to go quickly back to oral HPV data from vaccination that I noted from that ACTG study, where there was probably maybe a benefit from quadrivalent vaccine. There was another study of one of the bivalent vaccines conducted many years ago. And this is an interesting study because instead of a placebo arm, women received a hepatitis A vaccine, since that wasn't introduced in that country at the time to kind of, not have maybe a vaccine reaction to really create a better placebo. But when women exited the study, they were obtaining oral gargles and looking for HPV 16 and 18, which were the two types the vaccine targeted. And women who received were assigned a vaccine arm had less oral HPV infection than those that received hepatitis A. And we've actually seen this from the NHANES cohort. So looking at people in the cohort whoever was astute and designed it to include an oral gargle, kudos to them, because what we've noticed is people that have been vaccinated with HPV have less detectable oral HPV. Now, this shouldn't surprise any of you here to see that men have more prevalent oral HPV than women, but we've already kind of told you that they tend to get more of this infection. Now, there's lots of theories behind that. We're not going to discuss them, but maybe there is an effect of vaccine on at least persistent oral HPV infection, and that this could be one means of, particularly if we give it in adults, of a way to drive decreases in oropharyngeal cancer. So there are two large randomized clinical trials of this to basically show does vaccination of older adults lead to decreased oral HPV infection. And one's an industry supported study. It's being conducted in multiple countries around the world. It's fully enrolled, and this is in men without HIV. And then a smaller study that's being conducted on older men with HIV in Brazil, Mexico, and Puerto Rico that I'm part of, really trying to figure out if this works or not. So what's next in the HPV vaccination? Well, really you need to validate 2 and single dose series in persons with HIV. This has kind of been done based on observational data in persons without. So the WHO has adopted a single dose series in their guidelines. There are 2 very large single dose randomized clinical trials ongoing in Kenya and in India to really validate this. And potentially this could also be a game changer if we don't have to sit there and worry about giving 3 doses. And as long as 1 dose is fairly equivalent, potentially we can increase the number of vaccines given. There is an expanded, one of the companies announced an expanded genotype vaccine. And there probably might be better HPV specific targets and other vaccine platforms that might work better than the current vaccine, but those are still in development. So my last slide, I just want to conclude that HPV infection is extremely common. Persons with HIV have much higher rates of cervical, anal, and oropharyngeal cancer when we compare them to the general population. And oropharyngeal cancer cases are rising, particularly as the population ages. Anal and cervical cancer cases are preventable. Screening guidelines do exist for those people with with HIV. However, access to HRA is still a problem. And really, the elephant in the room, of course, is this oropharyngeal cancer screening prevention. We don't have a lot to offer there. And before anyone accuses me of being an anti-vaxxer based on some of the data I presented, current HPV vaccines are very effective. We have great data to show that they're making huge headway in the world, including some data from Australia that I didn't show, but they really need to be given prior to sexual debut, and that's often pre-adolescence and frankly often before persons acquire or diagnosed with HIV. Just want to acknowledge particularly Dr. Mosiki, who inspired some of my slides based on a recent lecture she gave. And I think we'll go to this post-test question. Right, so which HPV-related cancer occurs more frequently in men? We, at least in the United States, I think we made this clear. I hope. All right, it's correct. Yes, excellent. So most of you chose answer C. So some chose B. The correct answer is C. And that's really in the general population. Now, I know men with HIV, particularly in the epidemic in the United States, MSM have more anal cancer than women, but that's not true in the general population. In the general population, women are about 1.5 times more likely to have develop anal cancer than men. All right, let's do question 2. So which age do the new CDC NIH guidelines recommend initiating anal cancer screening in women with HIV? Most of you got this right the first time, so I'm really glad that people are paying attention to that. Let's see if we can get almost everybody on this one. So 21, 35, 45, age of diagnosis. All right, we improved quite a bit. Excellent. So the correct answer here is C. Most of you did get this right the first time and the second time. So really around age 45 is when the risk surpasses about 10 times the risk of the general population. And it's not clear if screening younger women will really lead to a meaningful decline in anal cancer incidence. And frankly, we still haven't done a great cost-effective analysis of any of these strategies, but that's underway. So stay tuned. Excellent. All right, I think we probably have a ton of questions. Turn it back over to Rand.
Thank you so much, Grant. It was really a tour de force, and I want to appreciate the tremendous amount of work you've done taking us from the natural history to the interventions to what we're doing in the clinic today. There are a number of practical questions, and I want to be sure to get to them because all our clinicians on the call will be changing practice following this presentation. So a number of questions around what to do in the clinic. The first very practical question: what anal symptoms are we looking for as we follow the algorithm?
Right. So yeah, so the typical anal symptoms we're talking about are we usually ask about bleeding, palpable lesions, itching is a common one, or pain, and that could be pain with defecation, in certain populations, pain with receptive sex. And those are the things that we really focus on in this group. Now, there's a lot of things that cause all those symptoms. So you're all going to probably have to become a little bit of develop minimal expertise in proctology, but the Ian's guideline, the one that I shared in the slides, is a great place to start because it talks about all those coexisting anal conditions that can occur as well.
Great, and you've passed on so many resources to us, and I will commend them to people on the call because it's great to have all those references and those guides. The next question is similar. What kind of abnormalities should we expect to see on the I'm so sorry. What kind of abnormalities will we see when we do the anal visualization and do the anal pap
Yeah,
on
so I think on digital anal rectal exam,
yes.
yeah, so it's a little bit of one of these things where you have to know what normal is a lot. So you have to essentially do this a lot before you really start to know what's abnormal. Because very small lesions, particularly these superficial cancers, should be detectable on anal exam. This is actually based on some prior proprioception touch studies, but yeah, so it really is a little bit of a practice makes perfect type of situation, but any palpable lumps or kind of gritty fillings, and you're really doing like a 360-degree exam of the entire circumference and the whole length of the canal, and really got to focus on about 5 centimeters of perianus, because we think about 15 to 20% of anal cancer is going to arise outside the anal canal. So you gotta, yeah, it's kind of a practice makes perfect type of situation.
Great. So we had symptoms that we ask for. What abnormalities would we see on the digital anal rectal exam? And then we did have a question about should we make the digital anal rectal exam optional to maximize the uptake for the anal pap?
Yeah, so I find that a lot of people won't turn that down, but they're a lot more apprehensive about proceeding to HRA, for example. Um, I think there's a couple of things a couple of tips that really can help. First of all, obviously you want to you would get any samples before you would do the digital exam, because the digital exam is going to introduce lubricant, and frankly, your cytopathologist isn't going to really appreciate you sending a swab of lubricant to the lab. But going slow and really trying to make sure that you don't induce kind of a sphincter spasm will go a long way to helping patients tolerate the procedure. And again, that's one thing that we found to be helpful is, just placing your hand on the patient and say, this is my hand, next you're going to fill X. And usually I don't find that to be a hindrance, because by the time I'm doing that exam, I've already collected the swab.
And there's a question about the result that you get back. I get a fair amount of scant cellularity, unsatisfactory for cytology results on anal paps. Do you have any recommendations to help get a good sample?
Yeah, so I think I can answer two questions here, because I saw another one in our pre-lecture questions, is what do you use to do this? We used rigid polyester swabs. You don't want to use cotton, because the fibers will end up in your media. But cyto brushes are totally fine as well. I just find the pointy tips a little bit uncomfortable for some participants. We pre-moisten them. And then the way to get a good sample is some of it's patient dependent. Obviously, people that have had recent sex, or a lot of our patient population uses a lot of enemas, despite us counseling them not to prior to these procedures. But it's really doing a full circumferential kind of applying pressure laterally, doing a spiral motion with the swab as you slowly withdraw it. And I tend to count down from 10. And I find that if I do a longer swab rather than a short, quick one, I tend to have less unsatisfactory cytology results. HPV testing is not dependent on the sample as cytology. So that's another strategy. If you're able to figure out financially how to employ that, potentially you can overcome some of these unsatisfactory results.
Thanks so much. And then I think you've answered it. Then there was a specific question about whether you should use a bristle type swab. Does that increase the yield?
I think there was one study that showed it did increase the yield. And again, I have a lot of my colleagues here use them because that's what they're comfortable with, and that's what they stock in the rooms, for example. I think the other important tip for a good anal cytology is realizing that most of the nociceptors are right there at the anal verge. So if you can kind of open the verge with this type of motion, and then pass the swab between the verge into the more distal canal, you're going to find that patients will find that a lot more comfortable. Whether if you just stab at the verge itself, you'll find a lot of people will clench immediately, and then you're really going to be challenged to get a good sample.
And there was a question about, can toluene blue still be used for op screening?
I don't use it, so I don't actually know. So I can't answer that question.
And then just to wrap up the questions about screening, what are your thoughts on self-swabbing practices for anal cytology? And so this would be for, yeah.
Yeah, so I think I think you're going to increase. What I know is you'll have more unsatisfactory swabs, and we have a lot less data on how well they perform. But as long as you're able to follow up those unsatisfactory swabs with a provider collected test, I think you could potentially, like I said, that the HPV pilot in Milwaukee did show they got more people into HRA clinic by doing that. They were using an HPV test. I think there's I think there's going to be a role for it because, like I said, I think the vaginal self screening is going to be pretty revolutionary in terms of cervical cancer screening.
And then there was another very practical question, and I think there are two questions that address this. There's a problem with receiving cytology results that are within normal, but when you do a biopsy, you find high-grade lesions. What advice do you have to offer for this discordance that we can sometimes
Yeah.
see?
So no test is 100%, but there are lots of clinics that just do all three that screen everybody with HRA. I don't think that's practical in most clinical settings, particularly given the limited number of providers and time. And frankly, a lot of your patients may not want to have an HRA if they don't need it. So I think we're going to have a lot better screening data from the anchor screening set. That's everyone that screened for the study. Because about half the people that screened for the study had a high-grade lesion and half didn't, at least based if you're using HRA as the gold standard. So we'll have better data on what is probably the optimal screening approach. Is it cytology? Is it HPV? Is it, because there are definitely people with normal cytologies, and we did see this in our anchor site that would end up having a high grade and still got on the study. So no test is perfect, of course. No test has 100% sensitivity. So
I'm going to switch gears and ask a few questions about oropharyngeal cancer. Are there any oral screening tests available for HPV?
Yeah, so all the oral HPV data I showed you are based on their research assays, primarily based on oral gargles using a commercial mouthwash. And you spin that down, you get a pellet, and then you resuspend that and run a PCR assay on that. But right now it's all research based. I think the problem is again, it's like, does HPV infection translate into a lesion that you can do something about? Whereas I think some of these blood tests that are showing some promise, like the E6 antibodies, the digital droplet PCR, the circulating DNA tests, are more specific to like an invasive process. Potentially, you could screen someone and catch a cancer early where it could be treated surgically, like with just a tonsillectomy or something like that. So I think that's where we're going.
Great. And one of the questions to remind us that there's also inspection and palpation.
Yeah. So the classic case is someone is driving in their car, they're stopped at a traffic light, they feel their neck and they note a lump, and then they, call a doctor. So, I mean, everyone should be having a dentist look in their mouth. And I think dentists do need to be aware, particularly in these higher risk people, that they should be, referring anything that looks abnormal in the pharynx for evaluation. And I do see a fair number of this happening, with a qualified ENT person. But right now that's where that is the recommendation, is essentially visualization and probably a good cervical lymph exam at your visits.
Great. Then there were a number of questions around HPV vaccines. I think one you answered, are there any therapeutic benefits of vaccination?
Yeah, we
Or
don't
you
think
just
we
stays
don't
as
think so. I mean, like the 099 is probably going to be the last nail in the coffin on that, at least for high grade lesions. There was a recently published systematic review for anal warts where they were giving adjunctive vaccine, including intralesional vaccine, and they saw some signal. But if you go and look at the studies, there was only one RCT included in that systematic review, and the RCT was actually negative. So I question. I mean, I'm glad someone's doing that research, but it's like I think if you're going to use it for warts, and I hear a lot of anecdotal data about people doing this, that still really needs to be evaluated in a well-designed trial. And there isn't one out there that I'm aware
right.
of right now.
Yes.
So,
And then what are your thoughts on HPV vaccination in boys and young men?
so it should be the recommendation. I mean, it should be recommended. I mean, particularly since men are getting more oropharyngeal cancer. It is the recommendation in the United States, and a lot of countries are expanding HPV vaccination. For example, I think Brazil just went to universal vaccination, and they're actually very early in their HPV vaccination of women, nationwide there. So it is very much the WHO's approach. It's the CDC's, the ACIP's recommendation, and really a status neutral approach. And I think the one thing that's really helping HPV vaccination do okay in this era of anti-vax type movements out there is this is a cancer vaccine. It's the only cancer vaccine that we have. You could argue maybe the hepatitis vaccines have some of that as well, but if you sell it like that and you don't talk about it as a vaccine for a sexually transmitted infection that virtually everyone's going to get anyway, it does seem to help with uptake.
There was a follow-up question on vaccines for older people. If high cost were not a factor, you showed the $300,000 per quality averted. Would you recommend vaccine for older people? Because you did show, a third of, at least a kind of a third decrease in cancer incidence, for example, which is something that's be
Yes.
an outcome. Yeah.
Yeah, so if you actually read the AICP recommendations, what the person that they talk about vaccinating in older age is someone who's been in a long-term monogamous relationship, and then is about to embark on a new relationship, potentially as a person that's potentially what they're wanting to target is somebody who's HPV naive with that type of language, I think. Do I vaccinate older adults? I think, for the sake of clinical engagement and other things, I do it because the vaccine's safe. But I do, spend a little time tempering expectations that it's going to, it's important to keep your screening, being compliant with screening and cancer prevention, regardless of this vaccination.
And then there was a question about the trends that you showed in the UK for a decrease in cancer. Could that be a result of a decrease in tobacco use?
Yeah, I think it's hard to sort this out, but I think they've had such a profound drop to, I think it's less than 4 per 100,000 person years cases of cancer. Just that has really changed since the onset of vaccine and in that age group. so in the UK, I think they have 82% uptake rate of like full vaccination, so people receiving 2 and 3 doses. And Australia is pretty similar as well, and they've seen similar trends that were onset from the time of vaccination. So it's really hard to separate the two. Was there a profound sudden drop in tobacco use in that population, that younger population? I'm not sure, but I think it's more attributable to vaccine effect.
And then there's a question, what data did the WHO use for the recommendation for single dose for people?
There's
and the question is for people with HIV, but it's not the WHO. Yeah, so I'll
Yeah,
let you
so
see
the
what the
WHO still
recommendation
chose
is.
the three dose vaccine line for people with HIV, I believe.
Yes,
They
that's
haven't
correct.
backed off that one because there just is no data. There is a small trial in Peru I'm aware of that's looking at this particularly in younger adults with HIV, so for example, congenitally infected HIV patients. So we're all hopeful that it works because, like I said, I'd rather not worry about getting a 3-dose series complete and focus more on screening and prevention and all the other things that we need to do for this at-risk population. But Kenshi, I believe, is including women with HIV in Kenya, so it should be we should have some data soon. Some
Yes.
good.
So just to summarize, the single dose, the WHO data that they use for the recommendation for single doses for people without HIV from randomized clinical trials, multiple trials, and we still recommend 3 doses for people living with HIV, but there are trials that are ongoing. And
Yeah.
then this is maybe a good question to end with. Will there be an age to stop anal cancer screening for people living with HIV?
Yeah, I meant
People
to
without
mention.
HIV at risk. Yeah.
Yeah, I meant to mention this because currently the answer is probably no, because the risk does increase with age. And likewise, cervical cancer screening in women with HIV, the guidelines are pretty clear that there isn't an upper age to stop. I honestly put that up to shared decision making. I have some very active, able-bodied 80-year-olds that still come and see me and that still have high-grade lesions occasionally, and still want to do the procedures. So I don't know that we're ever going to find an upper age like cervical cancer screening in general population where you get a number of normal screens at a certain age you can stop. I don't know that we're going to hit that.
Grant, you've done a masterful job today because you have really done what is at the heart of clinical medicine, combining evidence and research-informed clinical practice, helping us to do research-informed clinical practice. There's so much that's changing. We have new data, new methods, new tools, and you've helped us all update our clinical practice today and be ahead of the curve in what we offer our patients. Thank you so much.
You're welcome.
I've done so much today.
Thank you both. That was fantastic. We just have a few closing slides.
Here's information on the upcoming webinars.